Okay, today we're going through kinesiology lesson 2, bones and joints of the lower extremity. Okay, so as we know, our bones create support for our body. So our hip down to our thigh, our leg and foot and ankle is there to support the upper body upright in space. Easy enough. Every time we take a step forward, when we're in this swing phase, then the upper body is being supported by one leg for a short period of time. So if that happens and it happens correctly, the everything is lined up properly to allow you to just stay upright in space as this other leg swings and lands, and you kind of go side to side. You need pelvic and core stability to keep the body straight. Otherwise, you're going to be kind of wobbling and teeter-tottering when you walk. So in order to walk efficiently, these bones have to be set in this, the femur has to sit in the pelvis properly, right, in the socket. There has to be proper alignment with the hip, down with the knee, so this patella can actually track up and down this train track. So if you look inside the patella, there's an actual groove in here where the bone has to kind of slide up and down when you bend and move the knee. So if this femur is off, like if there's any sort of internal or external rotation outside of its normal functioning, especially if one side is neutral, the other side is rotated, then it's going to change the way that the foot lands and the knee tracks, and then it's going to put pressure on the ankle, put pressure on these bones and ligaments of the foot, and then that's going to cause issues with the feet. It can cause bunions, causing plantar fasciitis, causing you to sprain your ankle easily if you trip off a curb or something, or step in a gopher hole. So the bone alignment is super important for us to understand. Pelvic balance as well. If this pelvic is tilted too much, then it's going to put stress on this lower spine. It's going to put stress on the sacrum, which is going to limit our mobility of having the lower extremities actually swing properly and squat and move properly in space. Okay. So starting with the pelvis. I think of the pelvis as a giant elephant ear. So you got the top of the ear, then you got like the earlobe here, right? And you got like the hole for piercing for like an earring. So this is kind of an easy way to, if you're trying to figure the parts of it out, you can actually touch your own ear and kind of physically feel where things are. So that kind of helps me, kind of navigate the points of that if I don't have a skeleton in hand. All right, so let's just do, can I do the whole pelvis? Let's see. No. Okay, so the top of the elephant ear. All right. So this is the ilium. So you have the body of the ilium, right? You have the iliac fossa. Remember I said where an indentation where trees can grow. So you can just imagine a forest in this area, and these are the top of the mountains here, up here. So at the crest of the mountain, like literally, like if you're walking up to the crest of the mountain, this is the iliac crest, the top of the mountain. Then you walk to the edge of the mountain, and this is like a little diving hole, and you jump off, into the water. So this is the anterior superior iliac spine. So if this is the ilium and this is the spine of the ilium, this is going to be superior, meaning above. Like if somebody is superior to you, they're above you. It's going to be anterior because it's in the front of the person, right? In front of the pelvis on the anterior side. So anterior, front, superior, above of the iliac spine. Then below, this is going to be anterior in front, inferior, meaning below this one on the iliac spine. Okay. Then back here, we have posterior superior iliac spine. Then we have posterior inferior iliac spine. So these are 4 bony landmarks that are on the pelvis to determine orientation of the pelvis. So if you're coming and you have your patient in front of you and you're putting your fingers on the ASI is here, and then the ASI is on the other side. If you see from this side to this side, there's like a big tilt, then you know that this hip is higher than this one, and there's an imbalance in the sides, and then obviously you're going to have a leg length discrepancy. And if that person is coming in kind of with a hobble or wobble or some sort of gait problem, you're noticing like you're not walking straight. This is going to be an indicator of like, oh, no wonder, because you're not balanced at the pelvis, and the pelvis is not articulating properly to help you have a smooth gait. So then I'm going to deduce, okay, what is pulling this hip up? And then I'm looking at all the soft tissue and around that area to work with that connective tissue to get that pelvis to realign, and then working with the thigh and leg down, because if this is off, then you're going to be kind of teeter-totter, putting more pressure on one side of the body, causing that musculature to work harder. So it's probably going to be more contracted. The other side is going to be more elongated. So you're kind of working from this top-down approach. But if you can identify that there's this kind of hip hike, then you can work with the muscles above and below, and then work the legs. And then usually you can get some sort of correction in that discrepancy. It might not fix it today because it depends on how long they've been walking this way or using their body this way. But doing the leg length test of seeing how far their leg is, and kind of doing these bony landmarks, you can kind of get an idea of like, okay, this is my goal here to correct this, because this person's having low back pain, this person's having pain in their glutes or something. So having some sort of diagnostic testing is going to be good to actually, one, build a plan, and to educate your client or patient to say, hey, the reason you're having this pain is because of this. It's not probably because you've been sitting for so long, or you picked up the larger basket the wrong way. Like people just don't know why they're in pain. But the more they can understand, oh, like I'm doing some body pattern in my life, either statically, I'm sleeping funny, I'm laying on the couch in a certain way, I'm crossing my legs, I'm standing with my feet, spread apart for too long, like something that their body is doing in gravity for a long period of time is causing this issue. Usually, unless they have some sort of genetic disposition or something to the structure, but the more knowledge they have, it's like, okay, well, can we kind of correct the way you're sitting at your desk? Can we get up more? when you're working? Can you sit? Can you put a pillow behind your back when you're on your couch? Do you need to get a new couch? So like these questions are going to be kind of asked and have this dialogue. So then each time they come back to see you, you're like, okay, we're going to correct this problem, because obviously you want to fix this pain, don't you? Like you don't want it to come back. So now we have like an actual game plan to fix that problem. Because I think most people want to have some sort of game plan versus just, oh, it feels better, and then the client just leaves without any understanding of what they need to do, and they go back to their same lifestyle, and then they come back on this hamster wheel of pain. Okay. So now let's go from the inside. All right. You have your auricular surface here. So I don't know, like I think of aura as the energy around your body, or like your soul energy. And because this is attached to the sacrum, when they, way back in the day, I don't know what era, but way back in the day when they were really looking at the human body, human anatomy, they thought that the sacrum was the sacred bone where your soul was. So, like your soul is in here, and your aura is around your soul. So I think of that point where it intersects into the sacrum. So that's kind of how I kind of visually see it and understand this portion up here. Okay, next we have the arcuate line. So like literally like creating an arc from this side across to the other side. So the half of the McDonald arch here. Okay. So this is part of the body here. So you see how this is divides the main portion. Then underneath here, we have the greater sciatic notch, right? So if we look here and go to nervous system, you can see your sciatic nerve runs through that hole here. So this is the sciatic notch.
Here or here?
Right there.
Right here?
Yeah.
Okay.
Right. So it runs from your sacrum down through that hole, down the back of your ischium, behind your femur, and runs all the way down to your foot. So if you have a pelvic discrepancy of this pelvis is tilted or stuck or not moving properly, then the muscles surrounding this are not going to fire in the proper sequence. And then you can have the smaller muscles pinching and squeezing, putting pressure on the sciatic nerve. And then that person has this kind of shooting pain down to the back of their knee or down to their foot, depending on where it's pinched and how much. But sciatica is a common thing because people are immobile. They're sitting too long. They're not moving their hips. They're not moving their low back, their spine. They have poor core stability. So all this just kind of locks up, and then the muscles don't fire properly, and then the smaller muscles are used and engaged, and then they squeeze on this here, and then depending on how they move, it'll pinch, and then they move a certain way, and then it doesn't bother them. But it can be a debilitating condition for people. But we can prevent this from happening if we can help them identify like why this is happening, what they can do at home to prevent it, and then what we can do in clinic to actually help them with their soft tissues and correct the soft tissues best to create the mobility of the bones to articulate with each other. Okay. All right, so that's a greater sciatic notch. Then we go down here and we have the acetabulum. So this is the socket where the ball goes into. So the ball and socket. So your femur attaches into this socket. Right? So it goes into the socket, and then you have this labrum, which is, like I said, that rubber on your water bottle top to keep the bottle from shaving off the metal. All right, so this sits inside, and then you have ligaments that surround it to keep the femur in the socket, and then when the muscles pull, it pivots and rotates and turns this in the socket. When people have a lot of clicking and popping and pressure in the hip, this head of the femur can actually shift posteriorly, anteriorly, superiorly, and it can get stuck on one edge of the wall here of the cave. And then as you're moving, it's rubbing and grinding and rubbing and grinding. And then, eventually it'll wear down this labrum, wear down the cartilage. And then the more it's impinged, it's going to cut off blood and circulation. So then the tissues can't rebuild themselves. And then eventually they need to have a hip replacement. But we're here to do preventative medicine, right? And help them become aware of, just because your Nana had a bad hip doesn't mean you're going to have a bad hip. Like you can prevent this by really just being responsible for your health, but we're here to guide you however we can to help you really understand and take the right steps to loosen up the soft tissue to get this femur to go back in place, engage the nervous systems to fire the muscles in a proper sequence so that it can stay where it's supposed to be. And then you can walk and move and squat and bend and function normally without pain and be able to do normal activities, right? So I think that's the goal that everyone wants, is they want to be able to do normal daily activities and go for a hike if they want to, go play with their grandkids on the playground if they want to, like not be broken. But we have to educate them on how to prevent issues and be aware of their body and how it works. All right. Right. So we have the lunate surface of this acetabulum. So lunate, think lunar, think moon. That's inside.
And here?
Mm-hmm. Then we have the acetabular fossa, so like that little indentation. Mm-hmm. Oh, that's the ischium.
Here.
No. In the socket, it's just broken into. It's not.
Oh, okay. I see what you're saying.
Yes.
Yeah.
All right. Then on the posterior side, we have the tubercle of the iliac crest. So remember, a tuber, like a potato, you just have one little kind of bump sticking out from there. All right. So now going down to the top of the earlobe, this is your pubis, right? So this is your pubic area, right? This is your pubic symphysis that joins these two things together. All right. So we have the body of the pubis, right? So the majority of the surface area. Then we come down and we have the superior ramus. We have the obturator crest here. So we'll actually break down these words later so that you can understand them. You get the iliopubic eminence. So ilio referring to the ilium, and then pubic referring to the pubic bone. So it's that point there. All right. And then you get the pubic crest, like literally like the crest of the mountain, the edge. So we got the inferior ramus, superior ramus. And this is going to really kind of encompass the whole in here. So your ischium is going to connect down at the bottom portion. So this is like divided into different sections. All right. So we have the obturator foramen. So remember, foramen is a hole where things pass through. Right, just like in your vertebral foramen or foramina that your nerves go through, the nerve roots. And then again, this is going to connect to the acetabulum or make up the acetabulum. So this is the another piece of the bowl here. So like imagine like a porcelain bowl, and you crack it on the floor, and it's in different pieces, and you're putting these puzzle pieces back together. So the fossa, then you got the lunate surface, which is part of that moon, the other half of the moon. All right. Then on the posterior side, again, we have the body. That's the other half of the superior ramus. The inferior ramus down here. Same thing. And this is the pubis articular surface. So this is going to articulate or join with the ischium underneath. Okay. So now the bottom of the earlobe here. So you can think ischium is where you ish out of, right? So your anus is right down here. We've got the body, the largest surface is the body. Then on top, it's the underside of the acetabulum. So another third of the plate here being put together. Part of the fossa there. Then we have the rim that goes around. Down below, we have the ischiotuberosity. So this kind of large outcropping of the bone. Then we have the ischium ramus. So you have the pubic ramus, you have the ischium ramus, and those together are making the donut here. So the hole, the circle. And this part up here is going to articulate with the pubis, right? Making the foramen. Right? So all these together, these three sections make up the pelvis on one side. Then it attaches to the sacrum, and then, attaches to the other side, and then the pubic symphysis attaches it in your pubic area. So when somebody sits a lot, and they sit, on this sacrum, and they're putting all this pressure on these ligaments. Because remember I said our connective tissue is plastic. It can reform. And the longer it sits, the longer you put pressure on it, just like you put pressure on like a plastic bag or a water bottle, it's going to be harder and harder to reform it back into its natural shape. So if you've ever seen anybody with a square butt, like literally looks like a square, and they sit all day long at a computer or at a desk doing some sort of job, like their connective tissue actually forms into the shape of whatever they're sitting in, and they end up having like literally looks like a cube. Very weird. And if that happens and these ligaments get so tight and stuck and dry and they're not moving, then they're going to put a lot of pressure on this sacrum and a lot of pressure onto the pelvis, limiting the movement of the pelvis. So that person is going to probably have a lot of back stiffness. They're not going to be able to get a full swing in their gait and have like a long step. They're going to have a very short step, a lot of bang, 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 like pounding on the floor when they walk, because this is so compressed and locked up. And if you come here and you kind of put some pressure on the low back, kind of separating these a little bit, they're going to be like, oh my God, that feels so good to like actually get some movement, because they're just sitting and kind of locking up this connection point. So if we can go in there and we can work this area and get some mobility in the sacrum, then we're going to allow more nutation and more movement of the hips when they're bending and standing and sitting. It's going to take less pressure off of this lumbar spine, because wherever a joint doesn't move, the joints above and below are going to compensate and move for it. Right? So people who have like a lot of low back pain, their hips don't work properly to stabilize them in gravity and space. So then their low back, it's kind of like, we don't want to have any sort of problem with the actual spine, the spinal cord. So we're going to squeeze all these muscles to help protect here, because we kind of rely on the stability of these large muscles and the muscles in the abdomen surrounding this area to help take the brunt of the force and stability, versus these small, tiny muscles around the spine doing their giant job. So then a person's going to have just this restriction, and then it's going to kind of travel up to their mid back. It's going to travel down their hamstrings, and it's just, you'll see a pattern of, if this is locked up, it's going to lock up above and lock up below. So the more mobility we can get in the hips is key. If somebody has mid back pain, work the hips. If somebody has knee pain, work the hips. I feel like the hips are avoided too much because therapists aren't taught and they're not comfortable with it. And depending on where you're working, it's like liability purposes. They don't want you to work the glutes because somebody might complain or sue or whatever. But if you're there to care for people, you need to work those muscles and fascia and all these tissues, but you have to educate yourself to understand why, and then be able to educate the patient or client to say, hey, I understand that you don't usually get your glutes worked, but if we're going to help this low back pain, we're going to have to work these glutes and explain why and kind of what's going on. So, you know, it's like this is your dantian, this is your center of force. Like everything starts here and goes up and down, right? All right, so now going down to the femur. All right, a little more simple. Shaft, neck, head. Then we have, remember the trochanter, the T, the big T. We have the greater trochanter. Then we have the lesser trochanter. So big and small. In between these two, we have the inter, meaning in between, trochanteric, referring to the trochanters, crest, like the crest of a mountain, right? Then we have the quadrate tubercle. So quad meaning 4. Then we have the trochanteric fossa, right? The little indentation, kind of a flat valley in between the mountains. All right. Then coming down, we have the gluteal tuberosity. So remember, we have this kind of bony, rough outpoking of this bone where the glute attaches, the glute mat attaches to the femur down here. All right, then we have the linea aspera, which is just the line that separates the femur into 2 halves. All right, so just think of it.
Is it actually on the front or is it?
This is on the posterior side.
Okay.
So you can feel that long line.
Mm-hmm.
So that's the kind of line of demarcation from one side of the mountain to the other side. Then coming down to the back of the knee, to the popliteal area, you have the lateral and medial supracondylar line. So this is the condyle right here, right? So this is supra, meaning above the condyle.
Supracondylile.
Supracondylar.
Supracondylar.
Referring to the condyle. So it's the line above the condyle.
So these?
Yes. So you have the medial condyle because it's more towards the midline of the body. Then you have the lateral condyle, which is lateral.
Yeah.
All right. Then in between, we have the popliteal surface. So this is that soft space behind your knee.
Yeah. Hurts when you push it.
Mm-hmm.
And what's in here? Is this where the cruciates are? Underneath here?
So the cruciate, the cruciate is ligaments are attaching the lower leg to the femur.
Okay.
So think crucifix, like they cross over to help support all of the connections that this attaches to. Yes. So now, intercondylar fossa. In between.
Okay, here.
Yes. The condyle. Over here we have the lateral epicondyle. So if this is the lateral condyle, then we have the lateral epicondyle. So it's just like a little house sitting on top of the mountain, on top of the hill.
And up in here, lateral epicondyle.
Yes. So find the condyle
Okay.
and then just go to the far edge of, yeah, right there.
Okay.
Then on the medial side, we have the medial epicondyle. Also known as the adductor tubercle, because your adductor is attached to the medial side of that femur there. On the front, you have the patellar surface. Remember, this is in between the train track where the patella slides up and down as you walk in space. And like I said, if the lower leg is shifted, is like rotated medially or laterally, or there's some internal external rotation, there's some issue with your gait, it's gonna pull the patella off the train track, and there's gonna be more rubbing and friction, and then it's gonna put stress on those cruciate ligaments. And then if somebody lands wrong and twists, then they have like an ACL tear and like all these like soccer and like football tears where the foot lands, but then the knee turns.
Yeah.
Right.
Yeah.
So the more stability that the person has within those ligaments and the muscles engaging properly around the knee and then up at the hip, all the way down to the ankle, that's going to help stabilize that knee. Yes.
So I had a question. I remember one time when I was playing football when I was younger, I got tackled awkwardly. My leg kind of bent in the motion where, like you said, football, soccer player, basketball player, they would more than likely tear the ligament of the ACL or MCL.
Mm-hmm.
But I didn't because I'm like bow-legging this leg right here. This is the leg that bent. So he kind of like holding me a little bit because he's like a much bigger kid than me. My leg kind of like that. And most cases it would either be a hyperextension or like a torn ACL. So because of me being bow-legged, would that kind of give you more protection from that?
No, I think just because of your age. How old were you?
I was like 13.
Yeah, so being young, your body can take more damage.
Right.
It's more pliable, more flexible.
Mm-hmm.
Having that happen multiple times, then eventually there's like going to be an issue. But usually it happens to basketball players that are constantly putting force on their body. They might have had some sort of twist or injury or something happen before, but it wasn't bad enough. Mm-hmm. And then the older we get and the more we put our body through this stressful sport,
right?
Or if we're playing basketball and then we wrestle and then we play hockey, like we're, putting our body through all this stuff, mm-hmm. Eventually something might happen like that. Even like NFL players, they've been playing all through high school, college, probably middle school, and one bad tackle can put them out, but they probably had a lot of trauma to their body already that their body's doing the best it can to stabilize, and they're doing strength exercises and things. But, I don't think being bow-legged is going to help you. Mm-hmm. I just think it was your age helping you.
Gotcha.
Yeah. And he didn't come full speed probably and hit you. If he hit you hard enough, anybody can have damage,
Mm-hmm.
But
yeah, like where's AD? He was 6'2".
All right, so now going down to the leg. So just like anatomically, medically, when we speak colloquially, we say the leg is the hip down to the foot. But if you want to be correct, this is the thigh. This is the leg down here. So your tibia and fibula are the leg, and your femur is your thigh.
From here to here, from here to here.
That's your thigh.
This is your hip.
Yeah.
And
the knee down, the knee, like the tibia and fibula is considered your leg.
Leg, thigh.
Yeah. Okay. All right. So looking in here, so we got the patella over top of this intersection of the tibia and femur. So looking at the tibia here, so these sections here are where the condyles are going to sit into, right? Then in between, we have the anterior intercondylar area. You have the posterior intercondylar area. So anterior in front, inter meaning in between, the condyles.
The anterior
intercondylar, because they're in between, like entering the valley between the two mountains. Then we have the tubercles of the intercondylar eminence.
Just tiny little bumps right here, kind of.
They're like ridges, like you can see how it lifts. It's like a little hill.
Yeah.
Right?
Yeah.
Mm-hmm. So like literally like tubers, like bumps on a potato that you feel. Then in the front, we have the tibial tuberosity, right?
Here, under the patella.
Yeah. And this is where you're going to feel a lot of knee pain.
Mm-hmm.
All right. Why is you showing the tibia? That's weird. Anyway, so your patellar tendon attaches down here, right? So rectus femoris, and then you got your patella. This is the bursa sac, like you're cushioning. But then over this, you have patella, and then your patella tendon attaches down, and this slides up and down. But if there's any sort of rotation, like tibial rotation, if there's a lot of restriction, a lot of tension from like the hamstrings and quads and and your gastroc, all this, like if your leg is so tight that it's squeezing these two surfaces together, then when you bend, it's going to be kind of pulling on this tendon, and then it's going to be kind of pulling on this surface of the bone here. So a person can actually have pain on the bottom front of the knee.
Yeah. And
then usually you'll see somebody playing tennis and they have like a kind of like a band around, or like runner's knee, it's called. So they have like a band around it to help support. But it's a tension issue, and a lot of times there's tension in the leg because the person doesn't have the most optimal gait. So when they're running long distance, they're pounding the ground, but they might have a weird foot strike or some hip imbalance, and then that's going to cause all these muscles to tense up to protect the knee, protect the hip and ankle, but then that's going to put more tension on that one side of the knee. So usually a runner will have one side that they favor when they run, and then it's going to have that issue there. All right. So we have the tibia anterior border, So if you look at like a razor blade, you can feel your shin, the top of your shin. This is where people get shin splints up here from decelerating their body and
right in here.
Mhm.
Is that caused from like the slowdown?
Correct. Because when you're landing, your body has to use muscles to decelerate the foot and ankle.
Yeah.
So then if you're constantly pounding and leaning and braking, then it pulls the tendinous attachment on the tibia and over and over and over. You're yanking, and it makes little small fractures. And then if you have like really stiff ankles, or you have a weird foot gait, and it doesn't transmit the energy properly, then you can break harder than you should, and then it can cause issues with shin splints faster, so it's all about flexibility and stability balance. Like a lot of people like run or whatever, do activities, but they only do that activity, but they don't focus on recovery and balance and proprioception and stuff like that enough. So then their body just pushes through to get the sport done. But then we have kind of kinks in the chain. And then after a while, issues can arrive because the body is not pushing energy through the body properly. It's not winding up with the connective tissues to have this like proper force and spring load to exert the energy. So like the actual physics of the body can get off because of, people either don't know what to do, or they don't feel like they have time to do it, or you know what I'm saying? So there's different key factors, but it is preventative if we can figure out what is going on with the structure and how they move. All right. So now we have the tibia interosseous border. So we have the tibia, then we have the fibula over here. So this is the in between.
Help. I broke his leg. That's okay. Let's look at it.
Now you perform hip surgery.
We have the tibia soleal line. So remember, the soleus comes down underneath the gastroc.
So it starts up here. The soleus. Or can.
The soleus is like right underneath. Let me show you. So we got the gastroc.
Yeah.
Here. Then underneath,
Yeah.
we have the soleus. Right? And then you see how it goes on the angle here?
Mm-hmm.
So there's like actual line, the soleus line that runs down with the angle of right. So you see this here. All right, then we have the tibia medial border. So medial, anterior, and then interosseous border.
Interosseous.
Interosseous. So if we look at if we look here, this is the interosseous membrane. So we have this space in between the fibula and the tibia.
Mm-hmm.
Right? So this membrane is there to hold these two together. Otherwise, this is like you got this toothpick just kind of hanging off your body, it's not very stable unless it's attached to actually articulate at its pivot points here. So this membrane, is there to actually attach. So this is the interosseous membrane. So then we have the interosseous border where the membrane attaches to the inside of the tibia. All right, now going down to the ankle, we have the medial malleolus. I think of just like a small mallet. If you swing your leg and you kick somebody in the face, you're probably going to impact them with this part of the foot. It's like taking a mallet to the head. All right, then we have the tibia fibular notch. So this is where, remember I said on the outside that the actual fibula comes down and it intersects with the tibia. Okay. All right, now coming down to the foot. So we have, this retinaculum, this kind of slat bracelet that helps support the ankle. Cut that out, and then we got your tibia, your fibula, and then you have your talus. Okay, so this is the pivot point on which your ankle is going to dorsiflex and plantarflex and evert, invert, and this is the actual point of contact that moves.
The talus.
The talus. All right, and then coming below the talus, you have the calcaneus. Okay, the calcaneus looks to me like a hatchet from some Neanderthal, had some wood and stuck a sharp piece of obsidian or something in there and made a hatchet. All right, so then we have our tarsals, metatarsals, and phalanges. Just like in our hand, we have the carpals, metacarpals, and phalanges. All right, so we got, starting from the left, we have cuboid, which I don't know if I can isolate it.
It goes from lateral to medial, is that what you're doing?
Yes. So you see cuboid, it looks kind of like a cube.
This one or this one?
That one. It looks kind of like a cube, right? Then I want to go up here and we have navicular. So this one, if you look at it in a certain way, it looks like a boat, like a little canoe.
This one here?
Yes.
Okay, cuboid and navicular.
So you see how it appears to be a boat, like the actual, like a naval boat.
And why they wanted careful on the side, she's trying to find the caption of it.
Okay, thank you.
Thank you.
All right, so to finish up, we have the cuneiform, the lateral cuneiform, intermediate cuneiform, in the middle. Then we have the medial cuneiform, closest to the midline of the body. Then coming down, we have metatarsals. So starting from the big toe going out, 1, 2, 3, 4, 5. And then we have your big toe, which is the first phalanx or the hallux, right? So the big toe is called the hallux. Then you have the second, third, fourth, fifth phalanx. You have the proximal, which is closest to the midfoot, to the metatarsal. Then you have the distal phalanx, which is furthest away near your nail bed, right? And that is the pelvis, femur, thigh, right? Then we got the lower leg, tibia, fibula, then the carpals, metacarpals, and phalanges of the foot.